Hello, everyone, and welcome to our webcast. Today, we are presenting leveraging virtual technology to ensure seamless transitions in care for patients living with chronic conditions. My name is Lana Bira, and I'm a respiratory therapist, a certified respiratory educator, and the curriculum developer with a provider education program at the Lung Health Foundation. Just a quick reminder that the Ontario Lung Association became the Lung Health Foundation in February 2020. The Lung Health Foundation is dedicated to ending gaps in the prevention, diagnosis, and care of lung disease in Canada. We invest in the future by driving groundbreaking research and giving our patients and their families the programs and supports they need. Today, our presentation is 45 minutes. We will have approximately 10 minutes in the end to answer your questions. So please, if you have any questions, type them in the Q&A box. And a reminder for everyone that we're all going to be muted so we can hear our presenter well. And now it's my pleasure to introduce our great speaker, Anna McPherson. Anna is a respiratory therapist, certified respiratory educator, and certified tobacco educator. She worked with a variety of patients from neonates to geriatric population across a diverse setting, including primary care, community and tertiary care, and research. Anna's background includes knowledge and experience in complex chronic disease management, mental health, and addiction and social challenges. As a health educator in the past few years, Anna also received additional certifications in program management, HQO ideas, senior fitness instruction, tobacco cessation, motivational interviewing, brief action planning, and Stanford self-management program. Currently, Anna is working with an integrated comprehensive care program at St. Joseph Hospital in Hamilton. And her role there includes the facilitation of seamless transition of patients with complex needs from hospital to home, care coordination with outpatient hospital care team and community providers, as well as self-management education and system navigation for patients and families. Please help me welcome Anna, and let's give her a big round of virtual applause. And go ahead, Anna.
Okay. Okay, I'm just starting to share my slide. Let me just get this right here. There you go. Perfect. Okay. Hi, good afternoon, everyone. So thank you. First of all, thank you to the Lung Health Foundation and especially to the Provider Education Program for reaching out to me during this very interesting environment that we're facing. Thank you for giving me the opportunity to share my work experience and skills that I picked up along the way during my healthcare experience. Now, I want you to keep in mind that the foundational theme of this presentation is to think about how, as providers, can we leverage virtual technology. I'll give you some of my stuff that I've picked up along the way. And, you know, how can we use this technology in any way or form to ensure a seamless transition in care for patients living with chronic conditions. And from the flyer, I'd like you to know that some of the learning objectives that by the end of this presentation, you should be able to learn about various discharge planning tools, as well as risk assessment tools. How are we going to navigate this complicated healthcare system? And then how are we going to leverage virtual technologies for patient monitoring and self-management? And of course, the most important part is looking at that accountability transfers to avoid patient falling through the cracks. Okay. Now, just a quick review. I don't know if anybody's familiar with this literature. It was a 3-year study for high-cost users of healthcare published in 2016 in the CMAJ. And what it did was it characterized high-cost users of healthcare resources, which is essential into developing the appropriate intervention to improve the management of our patients. So this is a retrospective analysis of all residents of Ontario, Canada. They were looking at 2009, 2010, and 2011. Just to quickly look at my graphic here. So if you take a look at the top 1% of our high cost users, equating that to 33% cost of healthcare expenditure is what they're actually using. And then our top 5% uses about 65% of healthcare costs. And then our top 10% uses 77% of healthcare expenditure. So if you can imagine that the rest of us, the 90% who's not in that top percent, we're left with the 23% healthcare expense or cost. So we have to try and figure out how can we use this effectively and efficiently. Now, just a little more in detail, just for the analysis of the high cost users of our top 1% here. You can look and see, so top 1% of this is our population less than 18 years old, and they use about 38% of that 1%, and their cost per person is about $8,400 per year. And you're looking at these top 5 case mix group. So number 5, just to showcase respiratory up there for acute bronchiolitis. So the other top 1% accounted for 36% of that spending. And this is age group between 18 and 64 years old. We're looking at a spend of over $22,000 per person. And the top reason for hospital admission would include COPD, palliative care, and CHF. So now I'm building a pattern for you to look at, and specifically focusing on COPD and congestive heart failure is your 2 main chronic disease that we're focusing on. And lastly, the last group we're looking at in that top 1% who uses about 16% of that healthcare spending. You're looking at the age group greater than 65, and take a look at this. We're looking at just a little bit over $83,000 per year per person. So that gives us an idea that we need to have a strategy to help out these people living with congestive heart failure and COPD. Those are my top 2 in this case. Okay. Now, that was done during the old government. Now that we've got this new government, right? There's a new thing coming on the horizon with the Ontario healthcare reform. So this is great. So this first article here, or this first report that came out in January of 2019, a report from Dr. Devlin, who was the lead for this work. It talked about hallway healthcare. It's a system that's understrained, and it explored what many Ontarians have already thought about, already suspected that the current healthcare system isn't working as well as it could be for patients, for our providers, our families, our caregivers, and taxpayers. Now, to answer that, what kind of strategies are we looking at? So a second report came out in June of 2019, and this one was entitled A Healthy Ontario, Building a Sustainable Healthcare System. So what this is that we want to end or improve healthcare and then end that hallway medicine. So they started off again in December of 2019 here in Ontario. A strategy, their first thing that was on the table was put forward in terms of integrating the healthcare system. They started off with looking at 5 different provincial agencies that were started to be transferred into the Ontario Health Care Reform. And then while 14 local health integration network, or short for LIN, have been clustered into 5 interim and transitional geographic regions. Okay, so these changes, what they mean is to streamline the regional oversight as an interim measure. So it's moving the home and community care supports out of bureaucracy and into an integrated system within the Ontario Health Team. Now, you'll look at some of the recommendations. I named it the 10 commandments, which included 4 different themes. You've got integration, innovation, and you've got efficiency and alignment and capacity. So the first one, looking at patient-centered care, which is already self-explanatory. And number 2, improve the patient's and provider's ability to navigate our otherwise complicated healthcare system. Number 3 is support the patients and the providers at every step of the way in their healthcare journey and ensuring that there is effective primary care foundation. And then for number 4, or I call it commandment number 4, improve the options for healthcare delivery. That means increasing the availability or access in a variety of virtual options. Number 5, modernizing the home care sector. Provide better alternatives in the community for our patients. Number 6, you've got the data. It has to be strategically designed. Otherwise, by strengthening the partnerships between healthcare and social services, looking at that. And then as for number 8, we're looking at the healthcare system, transforming the design to make sure that there's financial incentives to promote improved healthcare outcomes for our patients. Looking at population health for the communities and increased value for our taxpayers. And number 9, we're looking at addressing not just the short term, but the long-term capacity pressures, including the wait times for our specialists and our community care. Just to give you an example, for a specialist referral, it usually takes about 6 months and sometimes to 18 months. We don't have that kind of time. And for community care supports, there is a wait list. We of course have to use that priority list, but there is a wait list for people needing supports at home. So how can we balance that out? And then number 10, the last commandments, is championing collaborative and interprofessional leadership development, focus on system modernization and accountability. So the good thing is, in alignment with the Ontario Healthcare Reform and introduction of the Ontario Health Team in place of the LHIN, there is a vision. This is the chapter 2 of that big report, a vision. There is a new, bold and beautiful vision of healthcare in the province of Ontario. Initiatives currently underway, such as the Ontario Health Team, which will create a system that is integrative, innovative, efficient, and able to respond to short and long-term needs for our patients. So moving forward, there will be ongoing commitment to achieve that quadruple aim, which you see on your slide right now. So again, improving the patient experience by establishing a seamless patient-centered care continuum from hospital to home, improve quality outcomes by reducing unwanted or unwarranted variation in patient care pathways. That means reducing length of stay in the hospital, reducing ED visits or unplanned hospital admissions, improving efficiency of the healthcare system by integrating all the resources across the continuum, avoiding duplication, and then improve the experience of the providing clinician, creating the conditions for healthcare workforce to find joy and meaning in their work. Okay. So let's take a look at this. So what does an integrated healthcare system look like? Okay. So in the current system that we have, healthcare providers in different care settings don't always work well together to provide coordinated care to patients. So you're transitioning between services can be really difficult. Communication, transferring, all those encrypted files that we have to make sure that we have in place. We need, in an integrated healthcare systems, patients should be able to connect or visit their primary care provider's office and leave with a definitely clear and well-defined treatment plan, a coordinated care plan from across the different systems. So what does full integration look like? It means one system, one team, a single point of contact, and one number to call. So there would be an emphasis on prevention and well-being, which would divert patients from hospital care level from seeking care from the emergency department, efficient processes, such as centralized intake, shared electronic medical records. These are your key features of a well-integrated healthcare system, because they are the tools that will help improve patient care and management, and they'll also improve the allocation of services appropriately and connect patients with the right level of care at the right time, right care, and right healthcare provider. So with the consent of the patient, integrated digital solution would make a patient's medical history easily and electronically available to the full care team, okay, of professionals working together to support the best outcomes of our population, specifically to that individual, our patient. Okay. So hold on a second, building on what we've already got this. And lo and behold, it's at the St. Joseph's Hamilton Healthcare System, our ICCP. We've got the one system, one team, a single point of contact, and one number to call. So you've got your patient, you've got one number to call. There's 24/7 access to a clinician's. The good thing is, instead of a number of people trying to figure out who to call, you've got one point of contact, you've got a coordinator. They use one digital patient record. Like I said, we need consent for that. And then there's one care team dedicated to that patient. So that's ideal of what it would look like. And yes, people are probably sitting out there asking, well, has it been tested? Yes, it has. So the St. Joseph Health System pioneering the integrated comprehensive care model for COPD and CHF patients. Here was tested, evaluated, and a report came out in June of 2019, where it shows that there was a potential to free up more than 13,000 hospital days and could save approximately up to 24.1 million in healthcare costs. So this was conducted by the UFT, affiliated with the Health System Performance Research Network, and the evaluation analyzed 6 existing healthcare programs in Ontario with the aim of creating a seamless transition. With the St. Joseph's Health team, there was a number of things here in the evaluation. If you look to the right of the screen, there were 20% fewer days spent in hospital, 37% fewer hospital readmissions, and 20% less of fewer emergency room visit. And this is where it's been approximated that we had 13,502 hospital days saved with this program currently in place at St. Joe's. So what do we have in place here with the ICC streams at St. Joseph's? We've got 2 streams. We've got ICC 2.0, the chronic stream, which covers the COPD and the CHF. And then we've got 3.0, which is the surgical stream. These are for planned surgeries only, and it covers the joints, the thoracic, esophagectomy, and urology. And coming soon to a program near you will be the gastro and colorectal surgery. All right, and here's just a picture, bird's eye view of our ICC 2.0 partner organizations. As you can see, I'll just point out a few things here. We are working collaboratively with St. Joseph's Home Care. We're working with our community paramedics, our St. Elizabeth healthcare system, and also ProResp. You'll get a copy of my slides so you'll get to see and review this. Now, the magic question is, or the billion-dollar question is, what's the eligibility criteria? Because this is great, right? And Georgia will attest to that. I'm hoping Georgia, she's on silent right now. She can't answer me. But this is who's eligible. So anybody that's community dwelling patient, but that excludes residents of long-term care, because we're assuming that they've already got the care that they need, right? And then anybody that's admitted to the H&HB Lynn hospitals for COPD or heart failure, and requires home care at discharge. The other thing is, patients with active LIN at time of hospital admission, they do have a choice. We give them a choice. We give them LIN services are available, but now they could also access or transition to ICC And then after the 2-month period, which is what our regular, in order to complete our program, it's about 2 months, they have that choice. So between the LIN and ICC, and then transferring back to the LIN if they've already been with the LIN program. And some palliative patients, so we're still working on that and fine tuning in that to see what else. Okay, but we're also looking into some of the challenges, right? You know, we're considering high users, you know, other chronic disease conditions that we're looking at that are high users. Looking at during this pandemic, for example, we considered accepting referrals from community and outpatient clinics like the Internal Medicine Rapid Access Center or the Heart Function Clinic to prevent readmission. So these are the kind of things that we're thinking of, or how can we support our high cost users? Okay. Okay, just like a little bit of a nice picture here. So we want a better experience for the healthcare journey from hospital to home. There was surveys done, and this is what our patients came up with. You know, delivering care with compassion, empathy. They want it to be patient-centered. They want it to be equitable. They want the care team members to be collaborative, coordinated, and they want them to communicate amongst themselves so they're not repeating themselves a number of times. The other thing that I pulled out from my bags of tools was this great, I would say, guideline. It's a summary of evidence and informed best practices, evidence and innovative practices from Health Quality Ontario, now called Quality, and it's under the Ontario Health Team, Ontario Healthcare. This is about transitioning between hospital and home. You're looking at the 4 different categories, what you need to do when the patient comes in, early in the hospital admission. And remember that the green is the evidence-based and the purples are the innovative practices that are going on or currently in place, and they're evaluating them. So early in the admission, for example, under this category, looking at performing med recon, assessing your patient risk of readmission, and I'll talk about that, what kind of tools that there is available, and then assessing your health literacy for your patient, okay? And then notifying community providers of patient admission. Some hospitals have already got the e-notification connected to LIN services. I know this happens at the Central LIN where I was before. And then collaborating with community providers to begin and update a coordinated care plan so that you're always getting ready for discharge, right? And you're prepared before that patient hits home, okay? And then the other categories, looking at throughout the hospital stay transition process, close to the time of discharge, they give you some, you know, evidence-based practice and also innovative practice. And then what do we do when in the community after a hospital stay? One key one that I wanted to mention was identifying one lead to do the medication recon. In the ICC program, it's the nursing that does that. And then ensuring discharge summary is available, and this is already happening for us. Following up with the patient within about 24 to 48 hours, and that is happening with the St. Joseph's ICC program. And then last but not least is designating a person in the community to support that patient along their healthcare journey. And that person is the single point of contact. What's unique to the ICC is that single point of contact doesn't stop at the walls of the hospital. They continue on and follow that patient all throughout for that next 2 months until their care is complete, and then transition is made to the next provider, a warm handoff to ensure a seamless transition. Okay, now I'm gonna jump into a different area here now. So let's get started. Another study that I pulled out, or another literature in my literature search. How are we gonna get started? What do we need to, what do we have, and how can we use these tools and resources to meet the population needs? So as we know that some older adults present with both medical and social and functional care needs, and they present often in the emergency departments and admitted to acute care. And then they're readmitted again to acute care, or they're admitted to institutional long-term care. So many are continuing to be managed in the community in the absence of an intervention because they don't know, they don't know what they don't know, right? They need somebody to support them and guide them, maybe a navigator. So a key component of an early intervention strategy is identifying that patient most at risk of high hospitalization. So when interventions are targeted to those most likely to become high users, then the likelihood of success and cost savings can increase dramatically. So that's why I like this little study that Dr. Woods, one of my favorite evaluator, Dr. Walter Woods, he's done a lot of evaluation with the HSPRN group. They looked at, these programs, intensive case, he mentioned that intensive case management and integrated care interventions have been developed to span physician and home care services to address the medical and social needs of that patients, right? But these are expensive programs, so they have to be proven effective. They have been proven effective, but not yet cost effective, because we need to know who the patients are, who those high risk patients are, and what are they needing? What kind of support do they need in order to keep them at home and in the community, okay? So in this study, there was a head-to-head study. It's a comparison of risk screening tools that was completed by Dr. Woods. And it was to evaluate comparative predictive strength. So at the end of this little part of the slide presentation, I'll show you which one. Here they are. Sorry, not at the end, but right now. So what did he compare? He compared these risk tools, which was one of them was PRA, which is the probability of repeated admission. It scores and identifies older adults who are more likely to need hospital admissions. And then you've got the SPQ, which is the Sherbrooke Postal Questionnaire. It predicted amount of community nursing care time. And then you've got this SMUF, not SMURF, but SMUF, the functional autonomy measures. Okay, it's for clinical purposes, planning and allocating resource. And this one you might be familiar with the MAPLE. It's method for assigning priority levels, which is important in Ontario long-term care. It's predicted long-term care admission within 1 year. So if you look at the side here on my left column, each of the categories that was covered by these risk assessment tools, they covered health, sociodemographics, utilization, medical and functional, cognitive, and self-care. So those are the kind of things. Now, from this summary, the results show that the PRA risk scores were predictive of acute hospitalization, ED and inpatients admission, but not for long-term care admission. The SMUF and the MAPLE risk scores were predictive of long-term care. And then although the SMUF is marginally related to MAPLE, there are different sets of risk being picked up by these measures. As you can see the difference, a little bit of difference, right? Two categories there, right? The PRA scores performed really well in predicting hospital admissions in community dwelling adults, categorizing as high risk accordance to the score. So this would be great if it was embedded into the primary care EMR system, because you can kind of figure out things before it even happens for your patients who are at risk, for example. Okay, so another set of tools that they looked at. So the first one was looking at community care, primary to community care. The next one is looking at for those people that are admitted in the acute care area, okay? We're looking at outcomes, visits of ED, readmissions, acute hospitals, and long-term care, right? And then if you look at the top, the first one that we looked at is the Veterans Affairs Hospital Risk Screening Index. And then you've got the Mary Naylor Transitional Care Model Risk Screening Tool. You've got the Texas Baylor Targeted bundle, eligibility assessment, and then you've got the 8Ps. I love that. I like it when they do the acronyms 8Ps, because then you can remember what are the 8Ps, okay? And then the other one that we're using currently at St. Joe's is the LACE tool, okay? So in summary though, with this one, with these comparison, guess which one came up with the highest, even though it didn't cover all of the different categories of socio-demographic utilization, medical, functional, cognitive, mental, and self-care. The easiest to choose, the LACE outscore. The LACE score outperforms other models in predicting acute care readmissions, specifically in the 30-day readmission. Okay, so with community-based screenings, most of the statistics were very low. Okay, statistics were similar and hovering in that area, and the LACE really was more prominent. Okay, so what would be really nice is to actually have a combination of the LACE score and looking at other risk factors. So there was a new development at the time of publishing of this study, and now it's been used. It's called the Harp Tool. It's the Hospital Admission Risk Prediction. Health Quality Ontario and CIHI, or the Canadian Institute of Health Information, collaborated to develop this tool. And there is a Harp Simple tool for community versus the Harp Complex for acute admissions. Now, just moving on, these are the recommendations that came out of that study. Okay, the LACE looks really good, right? At very high levels, maybe greater risk of death than preventable. So we want to know not the risk of death, we want to know the preventable, right? Readmissions. So when you're looking at these tools, what are the modifiable and addressable factors? Okay, what would I do if I were trying to make improvements for real people in real life? You start with a risk assessment tool as the discharge planner. Maybe you're looking at that, or maybe as a chronic disease coordinator in the primary care, you're looking at the PRA if starting in the community, and then LACE if starting in the hospital. Identifying the addressable, modifiable gaps that you're looking at. Some of these gaps maybe they don't have a primary care physician for medical follow-up. Who follows that? They might have to go to an outpatient clinic. We do have something like a COPD and heart failure discharge care team follow-up clinic. What if they're living alone, they're isolated, and there's no informal caregiver? The caregiver is somewhere else in other provinces. What other risk factors are you thinking of? Financial and social. Georgia, don't fall asleep on me. I can see you there. Now, what are we trying to do? Trying to prevent initial hospitalization when people show up in ED, so we can use the LACE score, for example, in this case, right? We need to continue identifying risk factors by examining the modifiable and preventable reasons that people are being readmitted. Okay, that's key. Okay, let's turn the page and go into discharge planning. So what are we looking at in terms of discharge planning? So there's this thing from the task force. Discharge planning is a concept fundamental to quality patient care and healthcare system sustainability, and it is reasonable to expect a common industry standard. Yes, of course. So what these different tools that we have that we've been using, well, they tend to have common the ability to assign numerical risk scores, right? Wouldn't you agree? Based on dozens and perhaps hundreds of risk factors like comorbidities, length of stay, current diagnosis, previous diagnosis, and the acuity of that current illnesses, right? And some tools focus on treatment options, risk, and care plans for specific conditions like COPD or heart failures. Others take a broader approach, looking at the entire population of patients in their communities. Whatever tool you're using, see if you can embed it into your EMRs. That would be the best. You can try and maybe create with your IT an algorithm so that it somehow look like one of these tools, which one would be the best for you. But most importantly, planning tools should be dynamic, contextual, applicable to all patients. That is, they need to take into account your patient population, and they must consider the community a patient lives in. So important. So you start planning early and reassess often. Measure and manage all the time. You're trying to evaluate, and from identification to intervention, you're following that patient. And then the health systems need the right risk model. Okay. So the goal is to transition patients to the right level of care, and most importantly, the ability for these assessment tools to be embedded with scoring and interpretations into your EMR in primary care, in community, and hospital. And the PROC could be done, the HARP in primary care, and then the LACE and the Blaylock in hospital settings. Now, I haven't mentioned that last one, the Blaylock, okay, but I will mention it in a minute. Okay, so this is what we're using here in the ICC for my discharge planning checklist. It goes over a number of the things that we've already talked about. It goes over safety at home. Okay, some of them that I can do remotely, some of them I'll have to ask the patient. Some of them I could look to see in their EMRs, see if they've got answers. In this page over here, I want to know what they know about their condition, right? And how they feel if they can control the illness. And then some of the social risk factors that we're looking at in terms of financial issues, their medication, or can they afford it, and so on. And then what other challenges do they have, looking at transportation, vision, hearing, mobility. And then looking maybe just a little, the tip of the iceberg here about their literacy. How did they learn? So this kind of gives us that peak. Did they learn by looking at pictures, being talked to, you know, that kind of thing, videos, or hands-on? What's the best way for them to learn? So I like that discharge planning. Maybe we could modify it a little bit more. Here's another one. Guideline referrals to interprofessional team members gives you an idea while you're at the hospital who needs to see these patients. That will help you with the discharge planning process of what are they going to need when they get home. Are they going to need OT or PT to see them again? Are they going to need the speech language pathologist who's, you know, recommending a certain care plan? Or maybe they just need to be seen by a registered dietitian at that point. So it gives you a little bit of an example here. Now, this is the one that I haven't really mentioned, that wasn't tested in that evaluation that I see. So this is a tool, wasn't included by Dr. Woods, but I thought it was worth mentioning and exploring. It's available in Meditech EMR. The software is already built in. So it gives you a combination of looking at function, cognitive, and a little bit of social challenges or risk factors, and then the scoring system and what you may need. So there's some recommended, for your discharge planning. So I do like this Blaylock tool. Okay. Another tool, the 8 Ps. Okay, the 8 Ps meaning stands for problems with medication, psychological, principal diagnosis, physical limitation, poor health literacy, your patient support, prior hospitalization, and palliative care. So this is a nice little tool as well. And you know what? When I was looking for these tools on the internet, not all of them are available for free because there's a licensure involved. So those are the kind of things that you may need to consider when choosing your tool. This one I found for free. Okay, it was developed here in Ontario. So it was kind of nice because even though it didn't go over the social stuff, it has a little bit of the cognitive, the mental health, it covered. It didn't cover some of the other risk factors that we would have liked to have covered. So basically focus on medical. But a high score of 19 will definitely show you a higher risk of readmission into the hospital. Okay, so anywhere that's higher than 10, that's when we're thinking about discharge planning and community support. This is what this tool gives you. This just gives you an idea of when I'm doing my discharge planning, this is a potential discharge plan. You know, for this patient that's 84 years old with COPD, I looked at a high care path. We provide the education based on the living well with COPD. So that patient might have nursing, PSW, OTPT, and you could see the schedule for the next 8 weeks. And I'll be looking at that patients on a regular basis. We have the program assistant that will do the welcome call. And you see with this one, nursing, PSW, RT, RD, PT and OT and others, okay? And also, I think I mentioned it really quickly. There was that 10 minutes left. Oh my gosh. Okay, the COPD clinic, which is my go-to. So I'm gonna skip my heart failure because it's a similar one. So navigating the healthcare system, right? The entire healthcare system is too complicated to navigate. We need a navigator. We need a systems navigator for our patient because that system is a maze, okay? How are we gonna do this? Well, let's take a look. So you've got the patient at the center, right? You need to look at that patient as a whole. You're looking at the physical health, which is what we focus on in the hospital, right? And then, but you need to focus on social health too, as well as the mental health, to be able to provide better health outcomes for our patients. Okay, I'm just gonna show you some of the things, some tips and links that you can go on to, like the healthline.ca, for example, for the different region. And when you go into this, you'll find a lot of different things for seniors care, for children, and it covers a variety of things for social support, community supports, housing, and so on for our patient. And even if the patient, if you're querying dementia or Alzheimer, it's all in this little website that we have here. Another link that I like to mention is the 211 Ontario Health Services, okay? Now this one is more of social supports, community social supports. So we can connect with that, and you can even call that number, so it's not just online. The next one is the 311 City Services. So for the Hamilton 311 City Services, right, it's more for municipalities. They're not open 24 hours. The other one as well, the 211 is not open 24 hours. But my next link, with any chronic conditions, you know that there's going to be an underlying mental health situation. There might be anxiety and depression. They've got this great website, the Mental Health Connects Ontario. It provides free and confidential health services. This one is 24/7. Okay. Now let's go about leveraging technology. The future of our technology. What are we going to do? We've already got what we have. Here's some success with eHealth Ontario. We've got Acute Care Connecting Ontario, Clinical Connect for clinicians, and in primary care as well, and community care. Organizations like Community Care Access Centers with eHealth Ontario technology is accessible. And then for our ICC here at the Hamilton Health System, we have Procura is our one system that community providers can jump in and see. The eHealth Ontario Health Digital, I mentioned again. The Connecting Ontario here covers Southwest Ontario. Connecting Ontario. Sorry, I made a mistake. I lied to you. Connecting Ontario covers Northern and Eastern and the GTA, Greater Toronto Area. Clinical Connect is the Southwest Ontario. You can find clinical data, patients' reports, their admissions, you know, dashboards. The Ontario Telemedicine Network, another government agency now that went under Ontario Healthcare, right? It provides programs and services in virtual care for patients and providers. Ontario MD is the one, it supports physician practices. It helps implementation and adoption of electronic medical records. There's about 15 certified medical systems out there, and it has 17,000 physicians and more than 1,000 nurse practitioners members. So Let's take a look at virtual technology. The value is access, 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 just like in real estate, right? Location, location, location. So for this one, you've got access, remote patient monitoring. There's a variety of them. The OTN we've got. Here in Hamilton, we've got the community paramedics. Real-time use of lab results, Life Labs and Dynamar can go into the patient's home and do blood work and be able to do the results for that. Virtual care for homebound patients. We've provided that with my dovetail with St. Joe's and access to providers during pandemic. So with our COPD and heart failure clinic, that's how we can access our providers during this pandemic. We've only been just doing phone calls or virtuals. Now challenges is going to be the same. Access, access, and access, only because there isn't it isn't equitable for our patients, because some people live in the rural area and some people live in the urban area who's got great, we've got depending on their internet capacity and so on. And some of my patients don't have a telephone. So how am I going to do virtual with them, right? So let's take a look at this. So there's a lot of different challenges as well. There's governance of compensation mechanism, regulatory barriers, security of personal information, and then digital divide and access to technology. Like I said, urban versus rural, and then cost of that technology. So with this new Ontario Health, they're looking at 5 pillars for digital health strategy. They want more virtual care option, expanded access to online appointment booking. Some of the primary care, the family health teams might have this already. Greater data access for patients, looking at their lab results, looking at their chest x-ray, being able to see right away within 24 hours, better, more connected tools for frontline providers. We have that. We have remote connectivity with our EMR system with Procura in the community. And then there's data integration and predictive analytics to make sure that we're always improving, right? So the proposed change, this is to ensure Ontario Health and Ontario Health Team can collect, use, and share information to allow for better patient outcomes. Okay. For our virtual interprofessional rounds, we've used it. We've used Zoom like what we're doing now. We've done respirology rounds, general internal medicine rounds. We've done patient family caregiver and provider meetings, looking at discharge plannings and trying to see what kind of medical support is available. We do our COPD and heart failure. We've always done this for the last year on a virtual rounds, looking at which patients need our care the most. Our virtual patient rounds, again, to make sure that we're in touch with community providers. We do, case scenarios with our patient, with the complex patients, to make sure, to ensure that we're providing them the support that they need to stay home and avoid ED visits. And I've mentioned a little bit of some of the tools: real-time access, remote access on mobile, email communication, pictures, my dovetail, which we're going to talk about in a second. Of course, if there's urgent concern, the telephone is our go-to. Non-urgent concern, email with encrypted, communication, or we would make sure that we communicate in codes sometimes. So if there's an MRN number, we don't put any patient identifier in there to ensure that there's patient privacy and confidentiality at all times. Okay. Importance of accountability, care transition. When the care is completed, ongoing communication with the patient, family, caregiver, care teams, the GP, assessment of their ADLs. There's a standardized process that we do follow. So from the 600 participants across the province that were surveyed, this is the biggest theme that they were looking at. They wanted respect and compassion, effective communication. They want to make sure that they're not retelling their stories 100 times. They want patient education. They want an action plan. They want to do, if they are experiencing certain signs and symptoms, they want action. They also want follow-up care and medication support with that medical, medication reconciliation, and timely and appropriate home care, not have to wait for 2 months for a PSW. So there is a standardized process for a warm handoff, looking at medication lists, discharge summary, and looking at an action plan, your interprofessional progress notes, consultation. Yes, this is like you're carrying a baton in a relay. You want to make sure you don't drop it because that baton is precious. Otherwise, you're disqualified. Okay, so in summary, factors that may affect readmission: premature discharge, inadequate post-discharge support, insufficient follow-up, therapeutic errors, adverse drug events, complications following procedures, of course, nosocomial infections, pressure ulcers. So we can do wound care and patient falls, but and also failed handoffs. So I'm gonna turn you to a very important special guest. Her name is Georgia Carberry, one of our participants in our program. I'm going to ask her a few questions. So, Gloria, can you unmute her? Can we talk? Or I don't know if she can hear me with some of the questions.
I can hear you.
Okay, can you hear me? So,
Yep.
Georgia, how did you find the Integrated Comprehensive Care Program? Did it help you after your hospital discharge?
Well, it's been a year since I was in there, and I still feel like I'm part of the ICC team. Whenever I feel like I'm struggling or scared, I phone you, and you help me no matter what. So I still feel like I'm part of the team. I've never felt I've been, passed off to anybody,
Now, how did the follow-up happen, Georgia, with you? What were the things available? What were your options?
I had several options. When I got home,
Yep.
I had the PSW, physio came, occupational therapist. I had counseling that came to the house. I think that was all, and my airbow, because I'm on, I should say, progress.
You're not going to let me forget about that. Okay. We also had video conferencing. We also had video conferencing with the doctors and the nurse practitioner.
Yes, I do. And I love it. I feel like I am part of your future,
Okay.
And
Thank you so much. Georgia, I also wanted to ask you about my Dovetail. You're a registrant for Dovetail.
Oh, I love my Dovetail. I find that my family doesn't bother me as much about my health because I gave them all the passwords so that they can all look on there themselves and they're not testing me every 5 minutes. But I brag about my Dovetail, to whoever and that will listen to me, that they should get it into their system, like North Hamilton Community Center. I talked to them about it, that they should have it installed, it would, because there's a lot of COPD patients that go there.
That's right.
It would be great for them.
Any last words, Georgia? Any last word of wisdom or recommendation to make your experience even better?
I last words of wisdom is St. Joe's is the best hospital in Hamilton. And if you're ever sick, you are the place to go.
Oh, thank you so much, Georgia. Thank you so much for this, because this will help other providers to be able to support and change for the better, right?
I haven't had the need to go back, because of your great care, and that it's just been wonderful.
Okay, so before we go, Georgia, I want you to be a part of this. We want to honor the frontline workers.
Oh, yes.
Okay, let me just see if I can get into it. Just quickly, I know Lena's probably shaking there in her booties.
I love the frontline workers, and I want them to all be safe, take care, and work hard.
Okay, I wish I could do this really nicely, but here we go.
And virtual
Oh no, it didn't do it. That was supposed to be, there you go. This is for all you frontline workers out there. Thank you very much. Okay, now I'm gonna take some questions. Let me just see. Some questions. Oh, okay. Do you ever connect with RTs from patients in primary care setting that would be following? Yes, I do all the time. There's so many RTs working in the community with COPD and heart failure. Actually, thank you for that question, Julie. We are in partnership with the RTs in ProRes, and they have their, there's a team that's specific for ICC, their CREs. They help us in terms of education because there's portions in the educational binders for RTs to teach, for physio to teach, and for nursing to teach. So that's how we connect with them. For some patients with COPD and heart failure, it's the mental health issues that cause them to go back to ED. Oh my God, Mariella. Yes, it is. Definitely. Maybe mental health issues, I don't know which one you mean, but with anxiety, definitely, with depression, and then some of the other things underlying as well is, multiple personality disorder, that kind of thing. We actually have in our COPD care team clinic, we have a social worker and a mental health person that we can connect with if that's the case. So, and of course, when they're admitted and it's a COPD patient, it's counted as an emergency visit, unfortunately. Okay, the LIN has RRT who also target this population. They are RNs, NP, and CREs. The LIN has, I don't know what is RRT, rapid response. I'm not sure what that means. Okay, that's great. I'm glad that's happening. In this one, I'm gonna go back to Nora. It says, in my experience, the patients discharged to ICCP are less medically fragile and are able to retain teaching. I'm an NP. Thank you. Yes, we do believe that. Thank you. We're seeing that as well. We don't specifically have inspired, but have tons of primary care RTs doing education, etc. Very similar to inspire that following. Okay. Do you use any virtual platforms for direct patient education? Who is doing the COPD CHF? I think I've answered that in the community. So there's a number of them. There's nurses, PT, and RTs, like I said. And I also do it when I'm doing a follow-up. I go over their COPD or their heart failure, specifically the action plan. More importantly is what I focus on. There's actually a set that I put together that I can share with you guys. My email is going to be at the end of this presentation if you want. Do you coordinate with the hospital physician if you have an urgent concern with the patient post? Yes, whoever is that discharging physician is my go-to, but I also connect with the MRP or the PCP, the primary care physician. Always, we give them an email, not an email, a letter that we've connected with their patient is ICC. Does ICC have designated allied health in the community, PTOT? We're working with the St. Elizabeth. So they have the PT, OT, the social work, SLP, and the registered dietitian. With the St. Joe's home care, it's the nursing and the PSW that are covered. And we have regular meetings and trainings and education on chronic disease management. Okay. I think I tried to answer as much as I can. I hope I didn't lose anybody, but I'll show you just, let me see if I can. Oh, there's some resources. I will share this with you. There's our email. There's my email, personal email at St. Joe's that you can email me with any questions that you have. I hope that this presentation was helpful to your practice in any way or form. If there was any other questions that I can answer, otherwise I'll redirect the question to someone else. for any answers. Thank
Well,
you.
thank you. Thank you so much, Anna, for this wonderful and a very unique presentation. And I also would like to take some time and thank Georgia. Georgia, was so wonderful to have you. And thank you for taking time joining us. It was great. I enjoyed it very much. I was smiling very much the whole time at the end. Anna, thank you so much. You did a great job. This presentation is going to be archived, and we will be posting it on our website. And if you have any questions, you have Anna's email. She shared it with us as well. Feel free to send it to us, to Provider Education Program. And the email is PEP, for Provider Education Program, PEP, at lunghealth.ca. And other than that, just a quick reminder that next Wednesday at 12 o'clock, the same time, we're going to have another webinar, the last one of our 3 virtual care related webinars. And this one is going to be called Delivering Virtual Care to Manage Chronic Respiratory Disease, Practical Tips for Healthcare Providers. Thank you everybody for joining, and have a wonderful afternoon.
Thank you.